this morning to our NCAS Journal Club. My apologies for my parrot in the background who's being a bit attention seeking at the moment. But before we start, I would like to do an acknowledgement to the country. We acknowledge the traditional owners of the lands we're on today and pay our respects to their elders past, present and emerging. So today I am actually really excited to have Professor Jill Francis speaking to us today. She's a Professor of Implementation Science in the School of Health Sciences at the University of Melbourne. She recently arrived and prior to that she had been extensively involved at very high levels in the UK. She's a Professor of Health Services Research at the City University of London, and prior to that, the Professor of Health Psychology at the University of Aberdeen. She's been involved in key groups and has worked across with multidisciplinary teams in the UK, wider Europe, Canada and Australia. And the reason why I have asked her to speak today is because I know that she has been engaged in some really important work around feedback and behaviour change. She specialises in behavioural approaches to implementation science, and really trying to understand the most effective ways to support changes in healthcare practice to improve healthcare and outcomes. And I'm sure everyone listening in today knows that this is the key hidden challenge in antimicrobial stewardship. So Jill, I'm absolutely thrilled to have you talk today and also to start our research relationship with you too, and look forward to your talk this morning.
Thank you so much, Kaz. Thank you for that very generous introduction, and thank you for the invitation to speak, and greetings to all the people who are listening in today. I hope you find this useful. So I've done quite a bit of implementation research in the antimicrobial stewardship space, but most of my work is across clinical settings and clinical problems, clinical implementation problems in a lot of different fields, but I'm trying to focus on AMS today for obvious reasons. So let's get started. Okay. So I'm just trying to work out how to progress the screen. Got it here. Yeah. Let's just start with defining our terms. So I'm taking this from the webpage of the BMC journal, Implementation Science, that gives a very nice definition. This is a journal that started up in 2006. It's a relatively recent journal as the field is relatively new. So here's the, quite a long way down this page, implementation research, the scientific study of methods to promote the systematic uptake of proven clinical treatments, practices and organisational and management interventions into routine practice. So a couple of things I want to point out. One is that the definition includes methods. This is quite a methodological field, as you would know. Another issue is, another thing to point out is that, yes, it's about uptake of new treatments in a range of areas, clinical, organisational, management. But most recently, and this sentence has been added to the webpage in the last couple of years, it's also about de-implementation of interventions that are of low or no clinical benefit, or what we've come to refer to as low value care. And of course, this is very important in the antimicrobial stewardship area. So it's very explicit now in the definition that yes, we're talking about uptake of innovations, but we're also talking about addressing the premature uptake of innovations or the persistence of practice that has been shown to be not helpful. So that's where we're coming from today. So this is a science, this is an empirical science, and I think sometimes people get confused between the difference between implementation practice, which is out there in the hospitals, in the general practices, doing this stuff, and implementation science, which is building the evidence base to inform that implementation practice. So this is what we're trying to do, build the evidence base. So just to mention, the implementation science journal impact factor is reasonably good for a young journal at 4.5. So let's define the problem that we're all here to discuss. And I had a look at the very, very well written or a report from the hospital National Antimicrobial Prescribing Survey of 2008 and previous years. In this report, we find some incredible achievements over the last few years. There's been development of effective monitoring infrastructure, large gains in engagement, which of course is a huge issue, increasing the availability of local guidelines, which naturally is very important for supporting appropriate practice. And over the past 6 years, very exciting achievement, the proportion of surgical prophylaxis given for greater than 24 hours went from 41% down to 28%. That's a really startling achievement. And improvements in documentation and thus in the validity of the data. And that is a hugely important central issue, isn't it, for audit? That if you don't have data credibility, you've pretty much got nothing in terms of its effect on clinical practice. So there was a very helpful table in that report that I've transferred into a graph, just to make some of the points that we're dealing with at the moment. First is have a look at the optimal appropriateness curve, and that's showing some very nice improvements. It was persistently around 55%, more recently trending up to 60%. We'd love to see that gradient steeper, that improvement higher, but that is a huge achievement. Then looking at compliance with therapeutic guidelines, persistently around the 45% mark over the years. And then non-compliance or suboptimal appropriateness, persistently around the 25% mark, and something that we really want to address. So this is a really, really helpful series of data points to show trends over the years and the impact of the hospital maps on antimicrobial practice. So in summary, we've got persistence of non-compliant practice despite numerous AMS programs, and we've got stubborn trends over the 6 years with a nice trend upwards of appropriate practice. And so the question is it possible to optimise the current approach? And that's the sort of approach that I'd like to take today. So great work happening. Can we make it even better? So this pattern of appropriate care and inappropriate care delivered actually replicates the patterns that have been found across all health systems, across all clinical areas since 1998. So there's been over 20 years of investigation of care in this context, with persistent recommended care being delivered to patients about 50% of the time. So we're up to 60% of the time in the NAPS, which is good in terms of comparisons. And perhaps more worryingly then, about 25% of care that's delivered is contraindicated, and that is a replication of what you've been discovering in the NAPS survey. So this is a universal problem, it's a global problem, it's something that is a stubborn problem, and so hence the rationale for implementation science. Can we do something about this? And can we do something about it in an evidence-based way so that we're not wasting our efforts trying things that don't work? When we talk about implementation science, a lot of people get sniffy, or sorry, when we talk about the behavioural approach to implementation science, a lot of people get sniffy and start to say, oh, well, if you don't intervene at the system level, you're not going to be effective. And I just wanted to point out that, again, nearly 20 years ago, Furley and Shortell, very highly regarded management and organisational researchers, pointed out that whether changes to improve quality and outcomes of care are top-down or bottom-up, whether they occur incrementally or radically, they will have to consider all 4 levels of change to maximise the probability of success. And I totally subscribe to that approach. And so, yes, we're taking a behavioural approach. Sometimes that's with individual staff. More often these days, it's with groups or teams of staff. But we also look at the organisational context and the system context, because these are going to be important moderators of effects of implementation efforts. And so international work is quite important because we want to compare systems and see whether our strategies are equally effective across different contexts in that sense. We also, of course, are interested in the patient level, and at a certain point, we're always going to look at whether we can measure the patient benefit for all these efforts. So within that context, let's go to some of the frameworks that we use, taking a behavioural approach to implementation research. And I'm trying to then use some examples from the AMS space to illustrate some of these frameworks. So implementation research, taking a behavioural approach, asks a number of research questions, and we use frameworks to help address those questions. And the first behavioural question is the guidance that we provide to people actionable? If people read a guidance document, do they then clearly know what it's asking them to do? And so we've devised what we're calling the ACT framework. It's not rocket science, it's a very simple framework. The paper was published in last year in Implementation Science, led by Justin Presso, who's a rising shining star in Ottawa, a former PhD student of mine, and we've developed a framework that is basically for coding guidance documents. Does the guidance very clearly state what the action, the desired action should be? What is the clinical action, the clinical behaviour? Who is responsible for performing that behaviour? Who's the actor? In what context should that action be taken? Who is the target? This is the patient group, the group of patients to whom or for whom or with whom we perform those actions. And most healthcare practice is time sensitive. So have we specified the time that this action should be performed? So as I say, very straightforward, very kind of logical, but it's very interesting how often this doesn't occur in guidance documents. So, sorry, I'm just going back to, we did a study, this is a paper led by Ailey Duncan, who was my research fellow in Aberdeen and is still in Aberdeen. And you can see from the names on the author list, you might recognise some of these names as some of the European people who are interested in AMS programs. This piece of work was led by the University of Dundee with Peter Davey and also by Craig Ramsey in Aberdeen. So this is taking a behavioural approach to specifying interventions that are targeting antimicrobial practice. So this is a documentary analysis. So simply looking at the documents and using the ACT framework to identify how well specified the target behaviours are. So briefly going to the results then, just to mention that this was a review of studies within a Cochrane review of AMS programs. There were 45 studies. Most reported what should be done, so the action, where and to whom, so the target group. But there were key details missing about who should act, who was responsible for acting, and when the behaviour should take place. And of particular concern was amongst 15 interventions to reduce the duration of treatment in continuing care wards. Only 3 of those 15 specified who was responsible for this behaviour. Now, we know from social psychology that when there's role confusion, when people aren't sure who's responsible for taking an action, they'll either fail to do it because they don't feel responsible for it, or they'll assume that somebody else is doing it. And so a lot of omissions occur from this role confusion. So specifying who is responsible is pretty important. Why would it be so poor? And I think it's because when we write guidance documents, we tend to adopt the academic style that uses the grammatical passive voice where there is no person involved in that statement. But I think we need to maybe transfer over to more direct language that specifies, especially for local protocols, because the person responsible might vary from place to place. But for local protocols and local guidance, quite important to say who's responsible. So That might just be a very low cost intervention that could make a difference. Or all of this is just probabilistically saying we might make a bit of a difference. So here's another framework, another theory, and it's addressing the question of how does feedback work and can it be optimized? Now we're going to talk a lot more in this hour about audit and feedback, but here's a theory that might help us think in a slightly different way about what's happening when we use an audit and feedback approach. So Carver and Shire's theory of the self-regulation of behaviour looks like this. This is a simplified version of the theory. It starts at the top, it's an iterative loop, so we go round and around this loop. Set a goal, do something, monitor, feedback, note the discrepancy between the goal and performance, and do some action planning. Let's take an everyday example. Let's say that during lockdown, I've decided that I'm going to keep fit by running for half an hour before breakfast every morning. So that's my goal. So I do that for, I go about my daily work for a week, sometimes performing that action. So I monitor each day, I have a diary, I note whether I've done it. At the end of the week, I give myself a summary, a feedback, a summary of what I've done. I'm noting then the discrepancy between what I did and my original goal. And let's say I was successful on 5 out of the 7 days, but I notice that on the weekends, I didn't manage to perform this behaviour. So I do some action planning. I say, okay, what am I going to do at weekends differently to make it more likely that I'll do this? Okay, I'll invite a friend to come running with me on the weekends. So I continue with the same goal and so on. And I loop around that cycle until I reach my goal of 7 days consistently performing that behaviour. So arguably, that's how audit and feedback works. Let's just keep thinking about this. Note that this theory is assuming that people start off with a high intention to perform the behaviour. This isn't about persuading somebody that running every day is a good idea. So you don't set a goal unless you're already motivated, unless you already think it's a good idea. You don't need to be educated, you don't need to be persuaded. All you need is some support to translate your good intentions into action. That's the assumption of control theory. So let's now transfer this terminology into the terminology of audit and feedback. So we set an audit standard. We note that people have been performing their clinical duties over a period of time. We audit that work. We then provide them with a summary feedback. Sometimes the feedback document will note, or quite often it will note, the discrepancy between the standard, whatever that might be, whether that's a peer comparison standard or an evidence-based benchmark. We note the discrepancy between that standard and performance, and sometimes in the document we will ask people to do some action planning in the light of that feedback to see if they can improve their performance. And of course the point is that then we continue with that, we cycle around that loop, hoping that performance will improve each time. Note we're still assuming that people have high intention. So if they never signed up to that audit standard, if they thought that that was not an appropriate standard, we're not going to get engagement with this process. And so that's something that with audit and feedback, in setting audit standards, we need to consider whether the people we're targeting are psychologically, as it were, signed up to those audit standards. Another thing to note, I've coloured some of these boxes yellow because we can note that those yellow boxes include what we call behaviour change techniques. They're actually techniques that independently of the audit and feedback process have been shown to be effective in changing back all sorts of behaviours in all sorts of areas. So this is quite a helpful theory because it contains behaviour change techniques, because it maps quite well onto the audit and feedback process. So we've used that in a number of studies now of audit and feedback, most notably in the UK, a 6-year program still being written up at the moment, a £2 million program of work that was looking at blood transfusion practice in hospitals, because Just like so many clinical practices, about 20 to 25% of blood transfusions are not necessary. And so again, we have this 25%, as it were, over-servicing of patients. So that's where we stand with the theoretical model. Let's swing then to, I think, a model that perhaps you're familiar with, the theoretical domains framework of behaviour change. This work was led back in 2005 by my brilliant colleague and friend Susan Mickey at University College London. This is the original paper that was published at that time. After 7 years, we decided in implementation science to run a thematic series, and I was one of the editors of that thematic series, to demonstrate to the implementation science world how the theoretical domains framework has been used over the time. And it was actually at that time in 2012 that we settled on the label theoretical domains framework. So if you search that label, you won't even find the original 2005 publication. We've been using the framework for quite a long time before we settled on that name. But so if you go to the that thematic series in implementation science, you'll find about a dozen empirical papers that demonstrate how the framework has been used to identify barriers and enablers to evidence-based practice. I should also point out that in that thematic series, there was also a slight update of the theoretical domains framework, again led by Susan Mickey, but the lead author here is James Kane, who's now in Canterbury, England. And so there are two versions of the TDF out there, just to point out. So the theoretical domains framework has been underpinned by decades of behaviour change research. It synthesises key factors that are associated with behaviour change. Out of 33 theories, there were 128 constructs. A lot of them overlapped, and so they could be distilled into 12 construct domains. And this framework provides a list of topics to explore, say, in interviews or in questionnaires that might affect behaviour. And it's used for understanding barriers and enablers to behaviour change among healthcare professionals, but also because it arises from general theories of behaviour, it can also be used for patients to understand the barriers and enablers to their engagement with healthcare behaviours. So here is the second version of the theoretical domains framework, and you notice at the top we've got knowledge and skills. Now when people, when clinicians aren't doing what we think they should do from an evidence-based perspective, we tend to say, oh, it must be because they don't know, we'll need to educate them, or it must be because they don't have the skills, we'll need to train them. But have a look at all the other possible types of barriers there might be. They might not think it's within their professional role, or there might be that role confusion that I was referring to earlier. They might have the skills, but they might not believe they've got the skills. They might not have the confidence to perform the behaviour, particularly say if it involves complicated communications with patients. People might not have the skills, but they might not have the confidence. What about beliefs about consequences? This is very much about the way clinical thinking goes. This is about whether you believe the evidence of benefit outweighs the evidence of potential harm. So that's a very important potential barrier for healthcare workers. Optimism, if people have unrealistic optimism about their patients will be fine, regardless of what I do, that could be a barrier. Reinforcement, if there's no specific reward for performing certain behaviours, they'll just go down to the bottom of the priority list. Then we've got intention, how much do people actually want to do this? Then we've got goals, including goal priorities. How high up the list of priorities is this particular behaviour? What about memory, attention and decision processes? Is it something that people simply forget to do because they're distracted in the moment? Is it a difficult decision, an easy decision? We've referred to environmental context. Things like, do people have the kit and the space to do the work that they are required to do? Then social influences. This was particularly, say, for junior doctors. Are they influenced by what they see as the norms within their work environment, or does their consultant ask them to do something that is at odds with what they think is evidence-based practice? Then there's emotion, what happens when people have had a very stressful day or when the patient is very distressed. And then challenges of behavioural regulation. And this is where people might be highly motivated, but in the chaotic context of clinical practice, they may not be able to organise their behaviour in such a way as to perform the desired behaviour. This is the behavioural regulation, of course, is what the control theory loop was looking to address. So there's a whole range of potential barriers and enablers, and I think the main message from this framework is don't just stick with the defaults of knowledge and skills. Have a look at the possibility of all these other types of barriers to change. So application of the theoretical domains framework gives us the research question for clinicians, for health professionals to change their practice. What are the barriers to be overcome? So again, looking at this European group, and Magda Zawuska was the research fellow in this work and led this publication, barriers and facilitators to implementation of antibiotic stewardship programs, transnational studies, and this refers to what I was talking about before, is we do need to compare across health systems because this gives us a good idea of what is generalisable and what is system specific. So this was a review. There were 8 studies that met the criteria. The most commonly reported influence on implementation of antibiotic stewardship programs were coded into the domain environmental context and resources. So people had problems with data and information systems, lack of key personnel, and inadequate financial resources. I don't know if you in NCAS recognise any of those barriers, but you seem to have done amazingly to overcome a lot of those. And then the other big problem was in the domain goals, specifically other higher priorities. And I often say that if we're doing a research project, then our research topic is our top priority, but it may not be the top priority for the clinicians that we're engaging in the research. And that might be totally fine, but it is something that we've got to think about. I mean, their priorities might be completely appropriate, but so we've got to make it easier for people to engage and easier for them to perform the behaviour that is evidence-based. We've got to think about, in quite sophisticated ways about how we can do that within the context of competing priorities, legitimately competing priorities. So then a research question is, how can the barriers be addressed and how can we use the knowledge about barriers to design implementation interventions? So we come to this point of what are the components, the active components of an implementation intervention. And from a behavioural perspective, these active components would include behaviour change techniques. So again, Susan Mickey led this work. This was quite a substantial UK MRC funded project of about £650,000 over 3 years. Building an international consensus around this was a really important part of the work, because what we wanted to do was to change the way people report interventions to make them more reproducible. If you've got an AMS program and it works and you want to replicate it, precisely what components of that program do you replicate? We need to understand very much more about which are the active components and which are simply, the unnecessary components, or that make it easier to deliver and engage with, but don't necessarily become the active ingredients of the intervention. So this is the logic of the behaviour change technique taxonomy. I should also mention that Susan went on then to develop that into what she calls the behaviour change wheel. And I think the innovation in this wheel is the idea of intervention functions. Intervention functions, broadly speaking, what are you trying to do in your intervention? Are you trying to educate healthcare professionals? Are you trying to restrict their options? So taking a drug off the list of potential drugs they could prescribe is a restriction intervention. What about environmental restructuring? Is there something that we can do with the spaces around the behaviour that could help? modelling. What about asking people to watch a video where a senior clinician performs the behaviour to show that it can be done, that it can be done well, that it's appropriate for a person in that role. Then enablement is about trying to remove some of those barriers. There's training if the problem is skills. There's coercion, and I think probably that is not appropriate, but sometimes people attempt to use that, and understandably there might be pushback about that. Incentivization, is this something that's so important that we should reward people for doing it? And then there's persuasion. Do healthcare professionals need to be persuaded that this is a very high priority, that the evidence base is strong? They might know the evidence, but just not be quite persuaded that it's such an urgent issue. So again, the point of this is to say, let's not default back to education all the time. There are a lot of different options. There are 93 behaviour change techniques, but even if you think in terms of broad brush approaches to intervention, there's a range of approaches other than education. And the point of this then is that what we do is to match the solution, the broad approach to the intervention, to the identified problem. So yes, if knowledge is the problem, if there are knowledge deficits, yes, of course, healthcare professionals need to be educated. If there's a skills deficit, yes, they need to be trained. But arguably, there are a lot of other ways that we could address different kinds of barriers. And this is the link between the theoretical domains framework and the intervention design factor. So now let's just turn then to de-implementation. So this is Andrea Patey, my very good friend and PhD student who was in Ottawa, came over to London to do her PhD, was also supervised by Jeremy Grimshaw, who's in Ottawa. Andrea is now working back in Ottawa and doing some fine work. Her whole PhD was on de-implementation in a behavioural perspective. And so the first publication from this was, what do theories of behaviour say about doing something more versus doing something less, about implementation versus de-implementation? What can we learn from existing theories of behaviour? And the answer was not very much, really. So the second paper that's under review at the moment is more of an empirical paper, and this was looking at interventions that have been reported in Cochrane reviews, in selected Cochrane reviews, and then those interventions were coded in terms of the behaviour change techniques that were included in the interventions, and also coded it in terms of whether the objective of the intervention was to ask healthcare professionals to do something more, to implement something, versus to do something less, to de-implement something. So what behaviour change techniques were used for implementation versus de-implementation, and broad brush results, the top 5 techniques for each of these types of intervention. We note that feedback on behaviour is in the top 2 for both directions of behaviour change. I note that instruction on how to perform the behaviour is also up there, quite importantly. The major difference, though, between implementation strategies and de-implementation strategies was behaviour substitution. If we're asking healthcare professionals not to do something, what are they going to do instead in a way that will be appropriate care, in the way that will enable the patient to see that they're taking their condition seriously, in a way that is evidence-based? So that's the challenge. So this is an ongoing program of work, but just to share with you that that's the sort of way we're thinking about implementation and de-implementation at the moment, not making the assumption that you use the same strategies to de-implement as you would to implement. And I think this is quite relevant for AMS programs. Now let's get to the real evidence base on audit and feedback. And this work has been led by Noah Ivers in Toronto, and some of you know Noah. He visited Melbourne last year. while he was still allowed to, as it turns out. And so you would know, I hope that there's a group in the Cochrane group called EPOC, Effective Practice and Organisation of Care. And within that EPOC group, there's a a review on, a number of reviews on the effectiveness of different audit and feedback strategies for changing clinical practice or improving clinical practice. This last review was published in 2012, so NOAA's in the process of getting funding now to update this review. But even back in 2012, there were 140 randomised controlled trials of audit and feedback interventions, and showed consistently that audit and feedback works. Median effect of 4.3% improvement in practice. But look at the heterogeneity of effect there, hugely variable, ranging roughly from 0 effect to roughly 20%. So this is the interquartile range, but some were meteorically effective. So this raises some questions, doesn't it? This is again is a question about, can we optimise the audit and feedback efforts that we're using at the moment to push more effects up towards that 16% and to ensure that we're not wasting our time by conducting 0% improvement studies. But most of all, let's not waste our time by asking the question whether audit and feedback works compared to no audit and feedback, because that question has already been answered. Yeah. So, accounting for heterogeneity of effect size, NOAA and team identified that if feedback is provided over multiple occasions, you're more likely to get a higher effect. Of course, this is totally consistent with control theory, that iterative loop. Then it's more effective if the feedback is provided by colleagues or supervisors rather than an impersonal document or website. That it's more effective if it's given in multiple formats, for example, verbal and written. And then also if it includes explicit targets and action plans to change behaviour in the light of feedback. And of course, those are behaviour change techniques. So we've already got some evidence that if those behaviour change techniques are included, the audit and feedback effort is more likely to be successful. So then NOAA and his mentor, Jeremy Grimshaw from Ottawa, have engaged in quite a lot of commentary pieces and further reviews and publications, trying to persuade the scientific community that repeating studies to answer the question that we already know the answer to is a waste of time. And what we really need to be doing now is to fine-tune these inquiries. Yes, let's keep doing audit and feedback research, but let's see which components are most effective, and let's play with this in a way that's going to gradually, incrementally improve the effects that we see. Note in this review, they noted that there are opportunity costs for patients, providers and healthcare systems when investigators test quality improvement interventions that don't build upon or contribute towards extant knowledge. We need to be knowing that we're building a cumulative evidence base here. This was followed by a no more business as usual paper. Let's set the agenda for this intervention because we know it's worth investing in. We know that healthcare systems invest huge amounts of money in this. Let's have a research agenda that enables us to build that cumulative knowledge base. And then how would you go about designing a study that feeds into that research agenda? And I've asked NOAA's permission to share at a general level this work, which is in progress currently in Ontario. It's funded by the Canadian Institute of Health Research Strategy for Patient-Oriented Research. The setting is primary care practices in Ontario. And just to note that Ontario's population is about 14.5 million, makes it a bit over half the size of Australia. So this is a big study. This is primary care practices across Ontario. The design of the study is a 2 by 2 by 2 by 2 factorial trial of letters to family physicians. They're the 4 factors: simple versus adjusted peer comparators. So comparing with the whole of the province of Ontario versus comparing with practices that have a similar demographic profile. Emphasis on antibiotic associated harms versus lack of benefit. If you emphasize one or the other, family physicians more likely to respond to one versus the other. Inclusion or not of what in Canada is called a viral prescription pad, which is a shared decision support tool, and then a repeat letter at 1 month post initial mail out. So Noah and team are trying to, as I say, fine tune our knowledge about audit and feedback. We know it's effective. Can we figure out which of the techniques within audit and feedback, which is done very variably across health systems, can we identify which variations are most likely to have a greater effect? There's also a linked theory-based mixed methods process evaluation where we're trying to figure out what are the mechanisms of effect of these different factors. And so when I talk about process evaluation, I'm drawing on the UK MRC complex interventions guidance. I'm going to just whiz through this because you're probably aware of it. You'll know that the first guidance was published in 2000, updated guidance looking very different. First guidance was trying to map onto the phases of clinical drug trials. Second, 2008 guidance looks very different and particularly focuses on modelling the processes and outcomes, understanding how the intervention works. If you think of an implementation strategy as a complex intervention, these are the sorts of research designs that are open to you and that we in fact use in a lot of implementation research. There's the theoretical work, the proof of principle. Sometimes that's already occurred historically, say, in the behaviour change space, but we need to set it into its context, into the chaotic, messy world of clinical practice and do the theoretical work and the proof of principle. Then we've got intervention design, overcoming barriers, and I've got these, I've listed the methods that we would use here. Then we look at implementation outcomes in terms of what are the attributes of the intervention, of the implementation intervention that might make it more successful. Is it acceptable to healthcare providers or to the recipients of the intervention? And we've developed a theoretical framework of acceptability to help us with that work. We've also got hugely important focus on usability, fidelity, feasibility, sustainability, scalability. All of these are investigations in their own right. Then there's the attributes of the response to receiving the implementation intervention, the response of healthcare professionals. This is about uptake, this is about engagement, and of course it's about whether they have the time, the headspace, the priorities to engage. Then we do what would have been called phase 2 trials, pilot and feasibility trials. A lot of process evaluations using qualitative and quantitative methods. And then, in a sense, the most exciting of all would be the randomised trial of an implementation intervention, where we look at whether the implementation intervention is effective in changing clinical practice relative to a control group. So, going on to Noah's and Jeremy's work in audit and feedback and how we can contextualise this work in a way that is efficient, that reduces research waste, and that is effective. And they've now for a while come up with, since 2016, that Lancet paper, the notion of implementation laboratories. And this is really my last point, and I wanted to emphasise this towards the end, noting that health systems have a need for generalisable evidence about how to achieve the greatest possible impact with their existing quality improvement initiatives. So can we bolt our research and indeed our randomised studies onto existing quality improvement initiatives that are set within the health system space to contextualise the work, and with a very little additional investment, work on achieving some high quality, high level evidence to support our implementation strategies. The essential features of an implementation lab are that research team works with a health system partner, that randomised evaluations are embedded into existing quality improvement efforts, that the more effective components are then adopted immediately and then tested against the next potential improvement. And this leads to a learning health system that has access to the latest evidence and a workforce that's already skilled for immediate adoption. And so that model is something that it would be fantastic to be able to set up in Melbourne and other places. It's already occurring in a number of places, and in fact, Ottawa and Toronto have initiated an international meta-laboratory of audit and feedback researchers and practitioners that meet together every year, or they did, now they meet virtually, a global community of science and practice that shares learning across the studies and across the laboratories, across the nations, shares expertise. And there is the opportunity for planned replication to explore the replicability of the wider health system and contextual factors that might affect outcomes for audit and feedback, and building an international community of healthcare organisations with these shared interests and research teams. So that's a very exciting development over the last few years. Just wanted to point out again that all this is embedded in the Cochrane Effective Practice and Organisation of Care group that's very active, and you can see at the bottom of the screen there, their objectives are very much about the sort of work I've been talking about. So the take-home messages then, an interesting mix of red and black there, that implementation science focuses on building an empirical evidence base for our implementation efforts. A behavioural approach is one perspective that includes quite a rich background of theoretical and methodological development. That implementation interventions arguably are complex interventions that can suggest a range of methods for us to use, and that evidence synthesis, that's very, very, very important element of building the evidence base, can be achieved through the EPOC group. And that's all I have to say. Thank you. I'd be very pleased to have any questions if we have time, or maybe we don't. Back to you, Kaz.
Oh, sorry, incoming parrot. Thanks, Jill. That is incredible. Can I ask one question, because I think people sometimes get a little bit confused about the trial aspect of implementation science. So if we take an example where we realise there are huge gaps in care, for example, in aged care, and we know that there needs to be better management of urinary tract, skin, soft tissue and chest infections, for example, it would be unethical to actually have a randomised trial of whether you put in because there are already clinical guidelines. They just need to be embedded in practice with the appropriate feedback. So the trial element is really about the methodologies to maximise the impact of the intervention. Is that correct?
Yes. Yes. So the implementation. Sorry, go on.
Go on.
I was going to say the implementation question is, if you, certainly. What's the control group going to experience? Absolutely. And what are the ethical issues around that? So the implementation question is, what would happen if, can we do better than delivering the guideline in the way that we would usually do it? So current usual implementation practice would be the control. So what do you normally do? What do you normally do when you go into an aged care facility? You provide them with a guideline, you provide them with, I don't know, maybe a workshop, an information session. What is normal practice? That's the control. Very much the same as treatment as usual in a clinical trial. And then the implementation question is, can we increase the effects of that guideline by co-interventions that are based on maybe a behavioural model, maybe some other model. And, it could be quite a simple intervention. It could be a second version of a guideline that is behaviourally specific using the ACT framework. It could be an additional video that people watch to identify, how you might deliver this in practice to to a real person in aged care. So it's the add-on that we're testing. Does that make sense?
Yeah, I just wanted the listeners to just hear your thoughts on practically actually what that actually means.
That's a great question, because absolutely, ethically, we would never withhold normal practice. Right. Absolutely, yeah, thanks.
Now, my second question really comes back to your pyramid, and I guess many of us have been doing stewardship across different levels, really at a prescriber level with our post-prescription feedback, academic detailing, restrictions, all the usual methodologies. My question relates to your thoughts around how to best provide national level feedback. And that's that intersection between what we're doing with our data and how the public respond to it and how that might change behaviour, rather than at the very prescriber level.
Very interesting. Yes. So I've got first a question back to you, Kaz. Who reads the national level feedback?
Well, that's a good question. It's usually put out as a public report, but of course, the people I actually don't know. They do usually have some media around it, but I suspect it percolates around the web for people who are actually already expecting the results or are engaged in the work.
But I guess that's a question. I mean, there's the issue about the granularity of the feedback. So if you say to Dr. Smith that your practice is different from everybody else's, there's a big incentive for Dr. Smith to change. If you say to the nation, we're not doing very well, policymakers will be interested in that. The Chief Health Officer, if he's got time, will be interested in that. Sorry, I'm just thinking of today's news. But does that reach the people who are performing the behaviours that need to change? That's the behavioural question. When we did the blood transfusion work, that was one of our first questions. We knew that reports got back to the transfusion practitioner, sorry, the transfusion lead in the hospital, but did it get back to the people who are actually ordering transfusions? Because if it doesn't, we can't expect it to change their behaviour. Unless the lead transfusion person decides to make up an intervention that might be effective or might not be effective within their hospital. So what we tried to do then was to create a dissemination pathway so that the report would filter down to the people who need to read it because of the changing practice. So there's two issues. Is the practice so general that people don't identify their own personal need to change their prescribing behaviour? And is it so high level, has it delivered at such a high level that it never quite filters down to the people who need to change as well? So I think it's very important to have that national level, but then a question is, and it's an empirical question, if we add to that national level something that attempts to get the message or the granularity of the feedback back to the coalface, as it were, is that going to be more effective? And it's an empirical question. I mean, we need to try that. We need to try that out. And most of these questions are going to be empirical ones, which is the whole rationale for this field of research. So it's a great question, and I would never say don't do the national level, but I would also say how can we optimise that?
Thanks, Jill. There's a question from Courtney. Thanks so much, Jill. A fantastic presentation. My question is regarding increasing the awareness of the importance of implementation science in Australia. What did you do in the UK? And do you think we can adopt those measures here?
Oh, wow. What a question, Courtney. Thank you. Well, there have been some giants in implementation science in Europe. And I have to say it was the 1980s where Jeremy Grimshaw and then someone in the Netherlands called Richard Grohl, a psychologist, who started publishing on with the idea, let's match evidence-based healthcare practice with evidence-based implementation. And that call has been going out since the 1980s. So this is a slow burn issue. And I would say that sitting on National Institute of Health Research panels in the UK in the last 10 years, most panel members in the room now understand what implementation research is. And of course, so much of this is driven by funding that we need to get funders to understand. And obviously with MRFF funding, the discourse around funding now, there is much more about implementation. I still don't think MRFF understands de-implementation. They've mentioned it in their objective, but so it's going to be driven by funders. So I'm making a couple of points. Really, it was 20 years before Europe got onto implementation science in a systematic way. It then filtered into the funding panels, and I think that then drove it forward. And in fact, I'm still involved in a European funded project where there was a specific call out for hybrid effectiveness implementation studies. And so that was the level of sophistication of the funders call. So, I think we need to be active in all of these areas. We need to be publishing, yes. We need to be talking about it as we are today. We need to be getting into funding panels. We need to be feeding back to funders that the problem of how to address de-implementation is a huge issue of waste in the health system. It could pay for itself if we funded more de-implementation studies and so on. So I think it's going to be a multifaceted effort, but it's going to take quite a lot of time. So that's the exciting thing. I mean, I'm really excited about being here.
Here at the good time,
and it feels timely to be here. Yeah.
A really fantastic question. One from Jennifer Apuan. Thank you. It's a very informative and interesting talk. So thanks, Jennifer. It has been. The next question is Jacqueline Bishop, who is one of our NCAS PhD fellows who's been working in the rural and regional stream with Kirsty and David Kong. How can we encourage and ascribe more value to publication sharing of unsuccessful implementation so that we can learn and not repeat?
Oh, fabulous question. Absolutely. So there's publishing in implementation science is now so popular that there's an offshoot, a sibling journal, Implementation Science Communications, and I think that might well be a place for a null result implementation trial. But absolutely, and again, this is about editorial boards. This is about publication bias, isn't it? Because that sort of bottom drawer syndrome where people don't have an exciting finding, so they don't even try to publish. That's in a sense one of the methodologies in the Cochrane Group is trying to identify that. So I think there are some journals that get that, or maybe we need to write more summary papers, more commentary papers about these are the things that we believe don't work or that haven't worked in these particular contexts. I think we always need to make it a bit conditional. Or it haven't worked, it may require a certain combination of interventions rather than this intervention doesn't work. It may work in combination with something else. So I think we've got a lot of uncertainties around what doesn't work as well as what does work. But yeah, great question. I think this is where the audit and feedback meta lab really good, because these are communities of people who care about this, who are sharing person to person with what did work, what didn't work, how they did something.
Next question is from Brendan McMullen, who is one of our PhD fellows. He's a paediatrician and he's doing antimicrobial stewardship, in particular working in the low value care. So encouraging home-based programs to get kids out of hospital early. So his comment is, fantastic talk. It strikes me we need to find ways to incentivise implementation research which is innovative, but also implementation practice which is proven.
Oh, absolutely. Absolutely. There's an incredible amount of touching certainty about what works what you have to do to implement something. But I think it's focused on innovation. I think that the low value care space is very different. I think people are genuinely uncertain how to stop that kind of waste. And I'm sorry, with all that excitement, I've forgotten the actual question, Kaz. Can you just...
Oh, it's really about how to incentivise implementation research, which is innovative, but,
yeah.
you know, using proven implementation methodologies and practice, I suppose.
I think
it's
right.
about one of the things, what I can say from my point of view, is that we do not have enough access to people like you as clinician researchers. It's like you've come down from heaven.
Thank you. Well, I mean, capacity building is a huge part of my role, and I really, really hope I can build, you know, a body of people who know about the field and who have the capacity, have the space to work with it. But I think the working in partnership with hospitals, working in partnership with healthcare providers and you know, large bodies, really important. Really important, because it's got to be a conversation as well as a piece of science.
Exactly. It needs to be embedded into clinical care, doesn't it?
Exactly. Yes. Yep. Thank you for the great questions. Fantastic. Thank you.
So I think we've hit 9:30. So again, lots of thank yous from people. They're very, so that the talk has been recorded and it will be put onto the NCAS website in due course. But on behalf of everyone and particularly from NCAS, you know, I really would like to thank you for a fabulous talk, Jill.
Thank you very, very much. I've thoroughly enjoyed it and I just wish I could see your faces, but maybe next time.
Thanks, Jill.
Thank you. Bye-bye, everyone.